Okay. Dear Pure Urology viewers, urologists, good evening one and all. Today our topic is laparoscopic suturing practicing. As you all know that laparoscopic destructive surgeries are easy, whereas laparoscopic suturing and reconstructive surgeries are difficult. Why? Because there is a lot of ergonomics involved, two-dimensional view, handling of the needle, suturing, all these are difficult. In addition to that, the practicing of the suturing inside the patient is difficult when you are a beginner because of the lack of patience, lack of adequate load, unless you work in government institutions. In private practice, a lot of the youngsters will be enthusiastic to do laparoscopy and laparoscopic suturing related, like lap pyeloplasty, lap ureteric reimplantation, lap urethrovesical anastomosis, etc. There is always a saying that if you practice, everything is possible and you can get it the result quickly. Today our speaker is Dr. Hemnath Anandan, who has learnt in front of me. I have seen who has learnt the laparoscopic skills in very short period of time, that is around 1 year, by practicing repeatedly, by understanding the logistics. That's why we have chosen Dr. Hemnath Anandan, so that he will be a role model to the juniors who wanted to practice laparoscopic skills before they do it on the patient. So with this introduction, he is MBBS from Kanyakumari Government Medical College. He is MS from Stanley Medical College, MCH from Madras Medical College, Fellowship in Endourology and Laparoscopy at Preeti Hospital under the mentorship of Dr. V. Chandramohan. Recipient of Professor A. Rajashekharan Gold Medal by TN Dr. MGR Medical University. Recipient of Professor A. Rajashekharan Gold Medal by Madras Urological Society 2019. Second prize in recently in USI Best Video 2022. Publications in national and international journals. Field of interest: endourology, laparoscopy and uro-oncology. And now I will hand over the program to Dr. Hemnath. He will demonstrate the basic logistics of laparoscopy ergonomics, basic sutures like square knot, basic sutures like surgical knot, basic sutures like left hand knot, and important sutures like other important sutures he will demonstrate today by giving a live demonstration on the chicken model. Now over to Dr. Hemnath.
Thank you, sir. First I will share my screen. Good evening, one and all. Really, there are no words to thank Chandramohan sir, because he has been my mentor, my lab guru, and also giving me the opportunity to talk in this esteemed forum, Pure FB. Thank you so much, sir. Today my topic will be how to practice laparoscopic suturing. The basics I am going to cover. I'll do this in two parts. First, I will show some basic about laparoscopic suturing in a PowerPoint presentation. Then we'll go on to the live demonstration in chicken module. Hope this presentation will be useful for the aspiring laparoscopic young surgeons. So as Chandramohan sir told, laparoscopy has now become mandatory for practicing urologists. Even if you don't do it, your patients demand it. The major hindrances to start laparoscopic practice in private practice are you don't have adequate exposure during your residency. Some of us may not have adequate exposure during residency, and during your initial practice, you will not have enough patients to practice on them. You don't see the lot of patients coming to you for laparoscopic surgery in your initial practice. And also, intracorporeal suturing itself is technically demanding, because whatever happening three-dimensionally inside, you'll be able to see only two-dimensionally outside. So there is a technically demanding procedure, the laparoscopic suture. I'll be going through this process of learning laparoscopic suturing step by step. Definitely, there are no shortcuts. You need to put in hard yards. A lot of hours of practice are required. But definitely having a mentor can speed up this learning process. You cannot skip the learning process, but you can speed it up with a good mentor. I am fortunate enough to have a good mentor like Dr. Chandramohan sir. Good thing about practicing laparoscopic suturing is that you don't need patience. Just you need patience, not patience. All you require, I will tell in the live these things, what are the requirements for starting laparoscopic practice, that I will show in the live. Ergonomics is very important. And any laparoscopic surgery is a taxing surgery. It will take hours. So you have to take care of how you stand, how you look at the monitor, how your hands are. Everything is important. Everything matters here. So here you can see the surgeon is looking at the monitor in a downward gaze, not upward gaze. Once your neck is extended, then you will have a lot of pain over and strain over the neck. You will not be able to do comfortably. And the second thing is how you stand, how much the height the table should be. Ideally, the table should go down as low as 70 centimeters. If you don't have that kind of a table, at least you should have a platform over that you can stand, so that the top of the patient's abdomen, this is the top of the patient's abdomen, that should be below your pubis level. That is the ideal table height. The platform also should be big enough to have your foot pedals like harmonic or ligature, or all the foot pedals you should be able to accommodate it in this. So you should have a bigger platform for this. Next, your stance. Here you can see that my arms are adducted by the side of my body. So the arms should be adducted, shoulders should be relaxed, drooping shoulders should be there. Your shoulders should not be elevated, and the elbow should be slightly in obtuse angle, like 110 to 120 degree, so that your elbows are not stiff and your range of movements will be good. And these are the correct postures that you should follow. The wrong postures I am showing here, your arms should not be abducted far like this, and your shoulders should not be elevated like this. Then your elbow should not be acutely flexed like this, like 90 degree or 60 degree. This is also straining to your elbows. You need to have idea about these angles. Even if you don't remember the names, you should have idea about these angles. The main angles are between your scope and your working instrument. The minimum angle should be 30 degrees. Minimum angle should be 30 degrees between your scope and the working element. And also between two working ports, the minimum angle should be 60 degrees. I will show a few examples for this for better understanding. If you keep those instruments in 60 degree, you will get this baseball diamond concept. The triangulation concept also the same thing. Your target organ should be straight ahead of your camera, and two instruments should be having an angulation of 60 degree. When you stand correctly and your angles are correct, those kind of abnormal postures will not be there. The elevation angle should be 40 to 60 degree. More than that, your arms gets adducted. Less than abducted. Less than that, you will have a drooping shoulders. So these are some of the surgeries. I will give some example. For example, for a nephrectomy case, your camera should be straight ahead of to the hilum. Hilum is the area of interest in a nephrectomy. So camera should be straight in front of the hilum. Your two working ports should be having an angle of 60 degree. Similarly, pyeloplasty, your area of interest will be PUJ. So your camera should be, ideally you should mark this area with either ultrasound, or you can have an extra port here so that you will have the correct position of the camera. So similar way, you can have this triangulation for all the surgeries. Wherever you want to operate, you have the target organ in front of your camera, and two ports will come by the sides in a triangulation fashion with an angle of 60 degrees. There is no fixed position for any port position for any surgery. Every abdomen is different. Every patient height is different. The width of the abdomen is different. The BMI, the fat thickness will be different. So every patient, you have to have individualized port positions. So varicocelectomy, every position, every organ, you keep that organ fixed and keep the camera port towards the midline and the two working ports by the side. With this introduction, now I will move on to the live demonstration of laparoscopic suture training.
Switch off please.
Now, these are the basic things that you require, basic setup you require before you start your laparoscopic practice. This is the simple laparoscopic training module. You can have a lot of local marketing persons that provide this. You could have fixed ports like this, or you can make it customized for yourself. So these ports can be changed if you want. They come with a inbuilt camera here. For demonstration purpose, I am going to use the HD camera. You don't need a HD camera to practice. This inbuilt camera itself is enough. And you need to connect it to a basic monitor that you have practicing. This is a HD monitor, you don't require this. So then you need some 5 mm ports and 10 mm ports. Next is the needle holder. You can have a straight needle holder or a curved needle holder. That is a personalized choice of the surgeon. I am comfortable with a straight needle holder. Next, you require a left hand holding forceps. Either you can have the Maryland. The Maryland will be precise, but it is little bit traumatic. You will crush the tissues if you hold it tightly. For precise suturing, like a peg stitch in a pyroplasty, you could use this Maryland so that you can hold it nearby in a precise manner. Otherwise, this is a fenestrated grasper, which is a kind of non-dramatic instrument, like a bowel grasper. This will not crush the tissue, so you can. I am comfortable with this instrument for suturing. Next is a simple straight scissor. For suture practice, the ideal suture would be a 2-0 vicryl. 2-0 vicryl is a wonderful needle. This needle is short, thin needle, long needle. It is very much user friendly, and this thread is also user friendly. For knotting and all the purposes, this thread is very, very, very useful.
Light is less, and we are getting reverberation of the sound. Something we have to do light. And you have to speak slowly, crisply. You are little fast, and the other sounds are coming. You can switch off the other camera.
That is muted, sir. Yes, sir. That is muted. So now the vision is better, sir.
Vision is okay.
Yes, sir.
Is the voice is from the direct cell phone?
No, sir. I am having a earphone.
There is some disturbance. Anyway, it's okay.
Okay. So I would suggest you to use a 2-0 vicryl for initial practicing of suturing, because this is very easy to handle. Don't go for the smaller needles like 3-0 or 4-0, because handling them is difficult. Initially, you may get demoralized. Once you are well versed with this needle, you can go for the other needle. If you feel that this is costly, you can use Sync 2-0 for as a substitute.
Why can't we use without speaker?
That camera will go away in the cell phone recording.
Through the cell phone, can we record?
Cell phone only they are recording, sir. I'm using earbuds now.
Yeah, this is coming better.
Okay, sir.
Yeah, better now.
Yes, sir. Yes, sir. Now,
Yeah, much better.
yes, sir. I'll continue with this, sir.
Yeah, like yes.
Yes, sir.
So
So,
you are using a 20 vicryl for practice, and you
yes,
are
sir.
using 12 centimeter length for the practice.
Yes, sir. The ideal length would be to 12 to 15 centimeter. I am taking little bit longer here for practicing because I need to do multiple knotting. So I will take a little bit longer suture here. The ideal
Okay.
length would be 15 centimeter.
There is one question from Sandeep. What
Yes,
should
sir.
be the distance between telescopic port and working port? Distance
Yes,
between
sir.
the two working ports. Is
Yes,
it
sir.
distance matters or angles matter?
Angles matter, sir. You should have, like I am showing it now here. If suppose our target organ is here, our camera port, how far the camera port should be. So ideally, that should be when you keep over the abdomen, it should be more than the half length of the camera. So it should be here, ideally.
Uh,
Next,
uh, okay.
next the working ports, I'll show here. So this is the target organ. With good ergonomics and stance, I'm keeping two of my instruments like this with an angulation between these two with 60-degree. You should not go more than 90-degree like this. Then your arm gets abducted. You should not be more close here. So 60 degrees is ideal. Automatically, the angle between this camera and the instrument becomes 30-degree. So this makes a good azimuth angle and this makes a good manipulation angle. So in this also, if you want to mark the where the entry point is, you should measure the half of the instrument, keep it here, half the length of the instrument you can mark here, and my port in this model working model is correct here. So for this target organ, this port is ideal. And similar way on the left side also, this is ideal. So this is how we plan the port for any surgery, sir. We don't measure the distance here. Usually we say that 4 finger breadths between the camera port and the working port. We don't measure these distances, sir. Usually we measure the angle like this. So now, next I would like to show how to introduce the needle inside the abdomen. So there are two methods. If you have a working 10 mm port, you can introduce that directly. If you don't have a working 10 mm port, you can remove the camera for a second and introduce through the camera port. So how do you introduce? So you should hold the thread very close to the needle like this, and you should slowly backload it like this. Go towards the target organ, not towards the.
Can you show again? It everything is dark here. We are not able to have the light in the. I don't know. Light is not there, and we are not able to see where you are holding the needle. Naresh, what are you doing there? Show closely where needle. Zoom, zoom and come close. Zoom, come close still come close. Yeah, come close. Yes. You are holding few centimeters from the tip of the needle.
Yes, sir. From
Yeah.
the tip of the needle, I am holding here.
Yeah.
And then I am backloading to the 10 mm port.
Yeah.
I am also directing the needle towards the abdominal wall, not towards the floor. So I am going like this.
Why?
So if you go towards the floor, there may be important structures like bowel or IVC, anything that needle can go and prick it, because this is a blind insertion of needle. If you don't want blind insertion of needle, what you can do is you can hold the back of the thread like this.
No, close. We are not able to see. Don't go fast.
Yes, sir. So hold the back of the thread like this.
Yeah.
And then with that working 10 mm port under vision. Now this is under vision, sir. So we can go inside, drop the thread, and that thread should be pulled under vision.
Yeah, it won't come. It is 5 mm now.
No, sir, I have 10 mm working port.
So like this, you can pull the needle under vision like this. This is safest method, but every time you don't have the 10 mm working port. In that case, you have to take out the camera and put it.
So you can directly insert the needle through the camera port, or you can put the thread from the right hand port if it is 10 mm.
If it is 10 mm. For
Yeah.
20 and 30, this is must, sir. For 40 and 50, you can use 5 mm port also, but that may sometimes damage the needle. 10 mm is safer.
Yeah.
So once the needle is inside, so where we should keep our chicken module for practicing. See, now my two instruments are coming directly towards the target here. And also the instrument is coming below the midline here. That is the ideal 45-degree where you operate. So you should place the chicken module in a way that the camera should directly go inside in a 45-degree angle without any depression or elevation. And also your working ports should be below the midline in the screen. This is the half of the screen. Our working ports should be
Let somebody else show half of the screen, and you show the ports. You put a ureteric catheter on the screen. Let the ports be below.
Half. So this is how I am standing, and my working ports here and my instruments there. Screen half. So that is the half of the screen.
So below the half of the screen, both your instruments should be there.
Yes, sir. Then only our ergonomics will be correct.
Right.
And also there won't be any strain for the camera person showing. He will not elevate or depress the scope for showing the target organ.
Okay. Now
next I'm going to show what are the movements of the instrument inside the abdomen. So there are intuitive movement and counterintuitive movements. What are the intuitive movements means? The front and the back movement are intuitive movements, and rotation, internal rotation and external rotation are intuitive movements. That means whatever I do outside, that is happening on the screen. When I want to pull the instrument back, outside also I am pulling back. When I want to rotate inward, outside also I will inward rotation I will make. But the counterintuitive movements are up and down movements are counterintuitive, and side to side movements are counterintuitive. That means you want to go up, you have to depress the instrument outside. You want to go right, you have to go left outside. These are the counterintuitive movements.
They are opposite movements outside.
Yes, sir. Opposite to the movements that I am making outside. So as far as possible, we should limit the counterintuitive movements in laparoscopy. So next thing I'm going to show is how to load the needle. So this is the most difficult step initially when you practice. There are two methods that you can hold the needle. First thing is dip and load technique. Dip and load technique is when your needle is in already forward loading position. All you have to do is go close to the needle, dip the lower lip on the surface, slowly close the upper lip. The needle will come into the position. So I'm going to show it again.
Slow.
Yes, sir.
Talk slowly. Talk slowly.
The needle is in the forward position already. All you have to do is go and open the jaws, dip the lower lip.
Video is not coming. Video is not coming.
Video is not coming.
It is coming slowly in an interrupted fashion.
Now it's okay, sir.
Yeah, you shall start.
Yes, sir. So
Yeah.
when the needle is in the normal position, all you have to do is go close to the needle with the open jaws. Your lower jaw should depress the tissue, and the upper jaw should slowly close like this. Then automatically the needle will come into position.
Very good.
This is press and load technique. always you will not be lucky. Your needle will not be in this position. It will be sometimes on the opposite position like this. In this case, what you can do is you can hold the needle thread close to the needle hub, and you can use the surface of the organ as the turning lever. You can turn like this and keep it, drop it like this, and then go and hold like this. This is the position you can achieve with turning over the surface. So again, I will show when the needle is in the reverse position, you can hold the thread close to the needle like this, slowly elevate, turn it on the surface like this, and drop the thread slowly, and you can pick the needle like this. This is one hand pickup technique. So this will be mostly, these two techniques you can mostly succeed in loading the needle. If the needle is sometimes in an awkward position somewhere other than your field of vision, you have to ask your camera person to immediately go and show the needle. And you have to go and pick the needle close to the thread, close to the needle, and first bring it to the field of vision. Your operating field, you should bring the needle. After that, you have to, this is the second technique I am showing. You have to hold the needle close to the thread close to the needle like this, like 1 or 2 centimeters away, and elevate it just few inches above the surface, and on the surface you can manipulate the needle with your right hand and hold it like this. So again, I am going to show that when your needle is in some awkward position, go and hold the thread with your left hand near the needle, little bit elevate that. Your needle will automatically come into the forward position, and slowly with your right hand hold it like this. These are the two techniques that you can follow to load the needle into your right hand needle holder. So after this, after you hold it, always this will not be in a perpendicular direction. Now it is perpendicular to the needle holder. Sometimes this may not be in a perpendicular direction. That time, see, now it is not in a perpendicular direction. Always your needle should be perpendicular to the needle holder. For that, you have to do fine adjustments. The fine adjustments, how to make, your left hand should come and hold the needle in the distal 1/3, 2/3 position like this. After holding, your right hand should come and hold the thread here, very close to the needle. This holding should not be too tight or too loose. If you hold too tight, this will jump out. If you hold too loose, so this should be not too tight, not too loose. Now you have to hold the thread closely here and try to rotate like this. This is called dangling technique, dangling of needle or dancing of the needle, so that you can make fine adjustments to make the needle perpendicular to the needle holder like this. Now it is perfectly perpendicular. Or if you want to take some bites in awkward positions like 12 o'clock or 1 o'clock, 2 o'clock, 3 o'clock, whatever clock position you want, you have to change the needle direction in this way only. This is called a dangling technique. This is very useful. So hold the needle 2/3, 1/3 junction with the left hand. With the right hand, hold the thread closely like this and rotate the needle like this. You can rotate 180 degree with this. Even this is useful for taking a backhand suture. So now you can rotate all 180 degree and you can hold it here so that you can take backhand bite like this. So for all these, you should learn this dangling technique. So for fine adjustments and for specific bites in specific positions, you need to know this dangling technique. So these are the three techniques of loading the needle. One is direct going and picking the needle, and the second one is holding the neck of the needle like this, and then picking with the right hand like this. The third one is holding the distal 2/3 1/3 junction and then adjusting the needle with the right hand and then loading like this. So these are the three techniques of needle loading. So I would advise you to repeat this procedure in at least 100 times before going on to the next step. So first you have to master this needle loading before going on to the suture. The common mistake what we do is once you are successful in loading the needle, directly we go for suturing. We should not be doing that. Do this at least 100 times. Repetition is the key to mastery. So do this 100 times before you go on to the next step. So now I will move on to the next step, that is taking a bite. So how to take a bite? After proper loading of the needle, you have to hold the edge of the tissue like this. And the important thing is the needle should make an entry perpendicular to this surface. This perpendicular entry is must. The same principles that we follow in open surgery should be followed in laparoscopy also. So this perpendicular entry is must. And then rotation is the movement that you should make here. Rotation, not forward pushing. Rotation you have to make. After the needle comes out like this, you have to stabilize with the left hand. Then only you should release your right hand. After stabilizing, then you should rotate and take it out. So again, I will repeat the step. After you load the needle perfectly, take the tissue and your bite should be perpendicular to the surface and then rotate. Rotate, stabilize with the left hand and then pull it out again in the rotatory motion. So once you have taken this out, you should re-hold the needle here itself, don't for the second bite. So that is simple way of loading the needle again. You should not be again searching for the needle. After you have taken both the sides, now comes the knotting. So here I would tell you first is square knot. In the square knot, you have two techniques with hands crossing and without hands crossing. I will tell you both the things. And the second thing I would like to tell is the surgical knot. And the third thing is the tumble square knot. These three things, if you learn, that is enough for most of the surgeries. So first is square knot with hands crossing. So after you have taken the bite, you have to, first thing you have to do is drop the needle like this. Don't hold the needle. Hold the thread closely here and pull the thread like this. Don't try to focus on the needle. Focus only on the short end of the thread. This is short end of the thread. Focus here, not on the needle. So hold the thread and pull it like this. You can use both the hands if you want. The short end of the thread should not be too long. It should be not too short also, so that it will slip out. This is ideal for this. This length is ideal, short length thread. Now I'm going to show a square knot with hands crossing. If you are a right hand surgeon, mostly you will follow this technique. In a square knot without hands crossing, you have to be ambidextrous. You have to use both your hands. For a square knot with hands crossing, you don't need to use your left hand for knotting. Next step is holding the thread at appropriate length. So now to make a loop, you have to hold the thread about double the size of this short end. Here is the ideal length of the thread that you should be holding with your left hand. So if you want to make a knot with the right hand, you first hold the thread with the left hand at an ideal distance to make a loop. Next thing you have to do is take your left hand close to the short end of the thread. So this is the short end. Your left hand should immediately come to the short end of the thread. Next thing, now automatically the C is formed here. This is the reverse C or the loop that you have formed. Now this loop should be straightened. So how to straighten that loop? You have to pull this loop with the right hand towards the right hand port. So this is my right hand port. I am pulling this thread or the loop towards my right hand here, right hand port here. Automatically this C has become stiff and I am ready to make a loop here. So how do you make a square knot first? First thing is, to make a rotation, you have to stay close to the left hand. This is the left hand instrument. This is right hand instrument. This left hand instrument should stay below. Should not be above like this. It should stay below. Then only your right hand can go above like this. You have to rotate closely, hugging the left hand instrument. Now your right hand instrument goes to the short end of the thread, and you hold the tip only, not here. You have to hold the tip like this. After holding the tip, you have to cross the hands here. Then only you will get a square knot. So this is crossing. So my left hand is going to the opposite direction. My right hand is coming to the opposite direction like this. Now the second knot, how do you make second knot? The same left hand should come to the short end of the thread like this. Now again the loop is formed here. And again you are straightening the loop like this. Now you have to go under. Last time I came above like this. You have to go under now to make a perfect square knot. So under I am going and making a rotation and holding the tip of the thread like this. And your knot is a perfect square knot now. How do you know it is a perfect square knot? These two threads should be below this loop. These two threads should be above the loop here. So this is a perfect square knot. Now you can tighten this. If you tighten like this, it cannot be removed again. So the third minimum vicryl requires 3 knots. So the third knot again you have to come above. First knot I came above. Second knot I came below. Now again I am going to come above. So how do you rotate? Rotate close to the instrument like this and rotate the instrument like this. Go and pick, and you have to come to the opposite side. So this is the perfect square knot with the using only right hand. I have not used my left hand for looping. So only the right hand I have used. But you have to
you cut the suture and show the square knot once again with a little explanation. You explained well.
Yes, sir. So I will remove this and I'll keep a new knot now. So I'm going to repeat the right hand square knot again.
Yes.
So, stabilize the needle and then rotate and take it out. Same open surgical principles. Drop the needle, pull the thread. After the ideal short end is there, now you have to hold the thread at appropriate length with the left hand. This left hand has to go close to the short end. Okay, this loop should be straightened. Pull towards your right hand port. Your left hand should stay below. Now I am coming from above. Rotation. Hold the thread in the tip. The other thing is that you need not cross 180 degrees like this. You can cross 90 degrees like this. This itself will form a square knot. So I am keeping it at 90 degrees crossing. The second loop I am coming under. So this is under. So under I am rotating. Again, you have to cross the hands. You should not forget to cross the hands like this. Again, for the third bite, third loop, rotating, and then cross like this. This itself is a perfect square knot with the right hand. Now I will go on to the square knot with hand without hands crossing. So for that you need to do with the left hand also. I will take a needle holder on the left side also. So I have two needle holders now.
Remove the threads which you have already so that confusion will not be there. Properly remove all the threads. That is also important part of the lap suturing, that whenever you have threads you have confusion. Remove this thread also. Why chicken model is more useful than the rubbers model?
Sir, the rubber model can be so stiff, sir. So initial practice on the rubber model will be tough. This tissue, this is similar to our human tissue. So you can use this tissue for better understanding of how it will be inside. The rubber model will be artificial, sir. It will be too tough.
Okay.
So again, I'm going to show the square knot with the left hand also. Now the hands without hands crossing. So drop the needle similar way, pull the thread. Now for the left hand knotting, you have to hold the thread with the right hand like this. And then you have to make a C loop, forward C loop. This is what you have made previously is a reverse C. Now this is a forward C like this. So similar way, you have to pull the thread towards the left hand port like this. And again, you have to make the loop rotation close to the right hand instrument like this. You can go and hold the tip of the thread like this. Now there is no hands crossing here. Already your hands are crossed to pick up the thread. So now you have to drop it like this. Now you have to be ambidextrous. You have to use right hand for the second knot. Hold the thread, pull the thread loop like this. Make a rotation close to the instrument like this. Hold the thread again. I'll again take that. So this is also a perfect square knot. The only thing is that you can see both the threads on one side above and both the threads on the other side below. So you can tighten it now. This is a perfect square knot. For the third knot, again you have to go for the left hand here. So right hand, left hand, alternatively you have to use the. So this is difficult in a real case scenario where you have to use both the hands. It will be little cumbersome. So always try to go for the right hand suturing with hands, little bit of hands crossing. So I'll cut down this thread.
Generator person ready.
So next we have to, now we have learned the square knot with hands crossing and without hands crossing. Next we will learn the surgical knot. I'll take one more vicryl thread for that. So here I am taking the ideal 15 centimeter length. Or you can have a measurement of your hands like this. From here to here is 15 centimeter for me. You can have a rough measurement like this and cut the thread roughly. now I'm going to show the surgical knot. Surgical knot is nothing but you have to take 2 throws initially. That is surgical knot. In tissues where approximation is little tight, you can use the surgical knot. So take the bite perpendicularly like. So pull the thread. Shorten. Now I'll make surgical knot with right hand. So again, hold with the left hand. Left hand should go close to the short end. After that, adjust the loop. Ideal. You pull the loop like this. Now you have to make 2 rotations for the surgical knot. Same thing, go above like this. Your left hand should stay below. Go inside. Stay close to the instrument. And then rotate your instrument like this. And then hold the thread like this. Again, we should not forget to cross the hands. Keep it like this. For the second knot, everything else is similar, only that 2 throws you have to make initially. So now I'm coming below and my hands are crossing. This is the surgical knot that we make with right hand. For the final third loop, I'm going above again. So above, below and above. So alternately, you have to go above and below. This is above, this is below. So this is the surgical knot. So one more knot I will show you. That is
Cut that thread. Cut that knot. Now only.
Sir, that is short thread, sir. I'll take one.
Okay.
For
Take out that needles and keep it in a side. How to take out the needle also you can show.
yes, sir. To take the needle out, same way, you have to hold the needle. You have to hold the needle.
Show the needle where you are holding. Yeah.
Yes, sir. The needle should be held, the thread should be held close to the needle like this. And the camera person should show the exit of the needle like this. Otherwise, sometimes the needle may get, thread may cut and needle may jump somewhere. That is a terrible complication, searching the needle inside the abdomen. Now for the tumble square knot, I am taking little bit longer thread. So where this tumble square knot is useful is where the tissues are under tension. So too far away tissues, when you want to bring it together, you need this tumble square knot. For example, if you want to bring the bladder and
wait. First you pass the needle, go inside and then speak. Because this is important knot and yeah, now you have put the thread inside.
Yes, sir.
Now please explain.
Yes, sir.
Tumble square knot.
Tumble square knot. For structures which are far apart like this, for example, I'm taking here this and this one here. So in urology practice, you will feel sometimes bladder psoas which you want to make. You need to bring the bladder and the psoas together. There you may need it. Otherwise, momentum, if you want to keep in a BBF repair or something, you want to keep the momentum, bring the momentum far away to the pelvis. These kind of situations, you may require this tumble square knot. So tissues under tension far away to bring it together without cut through.
Okay. Do you think that this keeping thread on one side is very useful?
Yes, sir. That will be confusing if you thread is in the vision.
Yeah.
Keep the thread away. Try to straighten the thread and then go for the knotting. So I'm taking this thick tissue here.
Yeah.
second tissue, I will take something here.
They are distant, they are under tension.
Yes, sir. This,
That you are showing the knot how to do two tissues under tension.
yes, sir. This is a chicken leg and the thigh. These two should be brought together. So for the tumble square knot, you should have a little extra length of the short end. You should not bring the short end too close. So little extra I'm keeping so that the knot will not slip out.
Yeah.
Other than that, all the principles are same. So here I'm going to do a right hand square knot. Here square knot is must for a tumble square knot.
So you are repeating the square knot again with right hand.
Yes, sir. Either you can do with the right hand or left hand. Either of the things is fine.
You are doing with right hand now.
I am doing with right hand now, sir. I am comfortable with the right hand.
Yeah. You are bringing the thread, you are making a loop, you are pulling the thread towards your pore.
Same thing.
You are going from above now. You are
Above now, holding
yeah.
the thread.
You are
And I am going to cross the threads like this.
Yeah.
So don't worry about the loosening now. It will be loose only. Keep it like that. And you finish the knotting first. So now again, I have to come under now. So I'm coming under now and taking the thread. Now you can tighten the knot. So don't worry about the knot initially. You can very well tighten it now. And then what you have to do is same side threads. These two threads are there that I am going to straighten to tumble the knot.
Yeah. What will happen with that?
That,
What will happen with that by straightening on the same side?
that knot will become a reef knot now.
Reef knot.
So yes, sir. So that will become these two threads. If you pull to away apart from each other, that knot will become tumble now. So that is the tumble square knot. Now you have to hold the thread tightly. You can use a Maryland or a needle holder for the left hand holding also here, and you have to slide the knot like this.
Very good.
So again, I'm going to hold it closer here. Hold it tightly here so that it will not slip, and you have to slide the knot like this. Slide as far as possible. When the tissues have adequately come together, you can stop that. So once the tissue approximation is good, next you have to do, what you have to do is untumble. Already we have tumbled it. Now you have to untumble so that it becomes again a square knot so that it will not slip. So now if you untumble it, it becomes a perfect square knot and it will not slip out. You have to complete the knot now. The third knot you have to take. Now previously we have taken only 2 knots to make it a reef knot. Now for the third knot I am going to come above again. First knot above, second knot below, third knot now again above. So hands crossing. These two tissues have come together without any cut through. This is the importance of tumble square knot.
Okay, it has come very nicely. Do you think where this knot is useful?
So in urology, usually for psoas hitch or to bring the bladder to the psoas or from omentum to the pelvis, these kind of situations, you may need the tumble.
Even PUG obstruction, distant ureter and
there we should not be suturing under tension. The tissues should not be under tension in
under tension. First, initially to bring them comfortable.
Yes, sir. Yes, sir. Without a crumpling effect, if you want to bring it nicely together, you can use this tumble knot. The same square knot, you have to just pull the one side of the thread apart so that it becomes a reef knot. Then you push the knot and then you have to untumble it. That is the concept. So the next thing I want to show is in suturing, how to suture with a short thread. Sometimes your thread becomes short. So that time you can have a, so now I'm using a short thread here.
Suturing with the short thread.
Yes, sir. Now I will keep this thread aside, or I will take it out. So this is a again
Short thread.
how to hold the needle. Just lift with the left hand, then the right hand comes and rotates like this. For fine adjustments, you have to hold the needle in the distal 2/3 position, and then you can rehold like that. This is a short thread. In that, the technique is you have to use the needle as also in the part of the loop, as a part of the loop. When you make the loop for knotting, you have to use the needle also. The needle curvature also becomes part of the knotting. So now my left hand is stabilizing the needle. While pulling out, you should be careful because this is a short thread. Now this is not adequate for knotting. What you have to do, you have to hold the needle here. Hold the needle and bring the needle towards the short end. Now your needle also becomes a part of the loop. So that curvature of the needle is also becomes a part of the loop. So now again the same crossing, everything is same. Okay. You will not have adequate loop here. So use the curvature of the needle here.
Excellent.
This is how you use the needle curvature for knotting in a short thread.
Excellent.
Cut it off.
The Girish Sharma is asking how to convert reef knot to square. Actually, square knot can be converted
Yes,
to reef, but reef knot cannot be converted into square.
Yeah, once I will show reef knot is nothing but I will show one reef knot, but that you cannot convert that into a square knot.
Reef knot is technically wrong. So once you make technically wrong stitch, you cannot convert reef. Reef is either non-squaring or suturing on only one thread.
Yes, sir. So
Show
for
it.
example,
You are showing the reef knot now.
yes, sir. The wrong knot I will show.
You are using same as the right hand in the beginning.
Same right hand I'm using. So now I am going above the above to make a loop,
And you
and
are
I will not
cross.
cross my hand.
There
So
only
this is
that is the first wrong. Show
Yes,
close.
sir.
Show close somebody. It is not crossed. See. Show
This
an
is
angle. Show an angle, Hemnath. Yeah.
yes, sir.
Yeah, like that. It is not crossed. Thread is against. This is thread is
Yes, sir.
against the knot. Thread is against the knot. You show
sir.
slowly squaring that. If you show how it will look like squaring, see, knot is free. Again you show reef. Again you show reef. See, two knots are slowly. Yes. Again you show square. See.
If you
Again you
cross
show
my
reef.
hands, it becomes a square.
This is square. Whereas if you put it in non-hands crossing, it becomes reef. Now if you throw another knot, no way it can be a safe knot. Throw another thread.
Next mistake I'm making is again I'm taking above.
Above.
If you take below, at least you can sometimes compensate. Again, if you go above, that is wrong. That is totally wrong.
100% wrong knot.
100% wrong. At least if you come below, it is 50% correct. Now it becomes a total.
Wait. Don't pull. That is the reef knot perfect.
Yes, sir. Now this knot, everything is on this thread.
Everything is on one thread. See, that is a reef knot. This
Now,
knot is totally unsafe. Now you pull out the thread, whether it will come out or not, shortened.
Now, if you cut the thread short like this,
By chance, if you cut very short, everything can come out
everything can slip out in a.
like that.
Everything can slip out in a go.
You hold
You
it
should
very
not.
long, it will slip out. So reef knot cannot be converted into square knot, whereas a square knot can be converted into reef by pulling the thread on the same side, isn't it?
Yes, sir. Yes, sir.
Yeah. I think we have spent 1 hour time. We will
Yes, sir.
conclude the session here. Excellent demonstration, Hemnath. Dr.
Thank you,
Hemnath
sir.
actually joined with us in 2019, Hemnath.
Yes, sir. 2019, I finished my.
2019 he joined, and we had these regular sessions in Preeti Hospital, and in no time, within 1 year, he has learnt all the knots and able to do pyeloplasty ureteric reimplantation with as much as ease as the seniors in the hospital. So, Hemnath, what is the take-home message you wanted to give?
Take home message: there is no shortcuts in laparoscopic suture learning. You have to spend a lot of hours training like this. If you have a good mentor, that process can be easily speeded. That message I have to give. If you have a good mentor, go and get training from them so that you can easily cut short this process. So I am fortunate that I got Chandramohan sir. Say a similar way, you can have a good mentor in laparoscopic learning. So once you are confident with the laparoscopic suturing, you can go ahead and do any laparoscopic case. Sometimes you'd be afraid of doing even simple nephrectomies. Sometimes IVC injury can happen, duodenal injury can happen, colon injury can happen. That time you need to convert the case to open. If you know suturing, the colon injury can be sutured, the IVC injury can be sutured.
Is there any way in routine cases we can practice lap suturing by colonic suturing to the peritoneum like that?
So how I learned faster is in Preeti hospitals we do all the hernias laparoscopically. That too trans-abdominal route we do, so that you will have a good idea about the anatomy of the pelvic anatomy. You can see the dissection skills you can improve, and also the suturing the mesh. We don't use tackers. We use the sutures. So taking bite in the pubic tubercle or in the anterior abdominal wall. The anterior abdominal wall suture is the most difficult. So if you practice placing the mesh and suturing the mesh to the anterior abdominal wall in a hernia case, you can learn the suturing faster. So
what about in colon dissection? Can we suture colon back to the abdomen and practice also?
Yes, sir. The peritor, that white line of Tolt again can be sutured back after nephrectomy or any pyeloplasty or anything. You can suture back. Long length of sutures you will have so that you can practice there.
So thank you very much, Hemnath, and very nice demonstration as expected. And hope this video session will be useful for the all upcoming budding urologists. And if they can respond us, they can give feedback on YouTube or on our website www.preetihospital.com, or you can follow the YouTube Preeti Urology and Kidney Hospital. Our YouTube is Preeti Urology and Kidney Hospital. You can join and follow these type of surgery regularly.
One more thing, sir, our all 4th Saturday workshops, we have included this lab training also in the afternoon session for urologists. That also.
This is for urologists where we have combined the RIRS, supine PCNL and laparoscopy, so that the people who come, actually there are no registration charges for this. All you have to contact is whatever the number we have given in the flyer, you have to contact. So thank you very much for being with us.
Thank you so much, sir. Thank you so much.